A lot of this stuff, you guys, is what was already on the Panopto, if you already saw the Panopto, but I updated it with just some information because when I went back and looked at it, there were some things that I felt were missing. So I don't know, you guys might or might not have already watched the Panopto based on the fact that you had an exam. I'm guessing that many of you might not have seen this already. Am I correct in assuming that? Yeah. Okay. All right, cool. Then you'll be able to hear it again when you listen to the Panopto, but I'll go ahead and move forward and talk about why I'm so passionate about perioperative transfusion strategies. And I think it certainly has been a passion of mine for a very, very long time. I've done a lot of research with blood transfusion, and I got to meet a very cool guy named Dr. Spies, who does all blood management. And I actually, if anybody's interested in a good textbook, not that you guys don't have enough already, but can you see this? This is one of my favorite textbooks. It's a practical transfusion medicine. So it's not just, I mean, it's very little actually to do with anesthesia. It's really all about transfusion medicine, but it really does help you to understand the whole thought process behind transfusion and why we give transfusions. And I belong to the Society for Advancement of Blood Management. And believe it or not, it's a whole society. There are nurses, physicians, anesthesia providers, just tons of different people who are involved, pathologists with blood. And it's all about what we can do to make changes. And so I'll just carry on from there. So I always start with my favorite slide showing the enculturation of transfusion and how, you know, it's been always deemed as, you know, give blood. It is a life-saving mechanism, and it really is life-saving in certain circumstances. We just need to constantly know about what are the risks and what are the benefits. So having a full understanding of anemia and what anemia does, having an understanding of a lot of the coagulation process as well, and thinking about things like testing thromboelastograms, super important before you decide to give any type of coagulation product. And the whole thought process of knowing that, you know, the blood that we transfuse into a patient is not going to work like their native blood ever. And it comes with a significant amount of risks. In fact, there's a lot of people that strongly believe that the blood, what we transfuse, RBCs, packed RBCs, it's really a volumizer more than anything else. We have a lot of studies that talk about the movement of transfused blood in our bodies and all of the risks of doing that, which I have some here, which I'll definitely talk about. TACO is transfusion-associated circulatory overload, and TRALI, which I'm sure you're familiar with, which is transfusion-related acute lung injury, and all of the fallout from these types of things that can occur, the pathological things that can occur. So this is just a little bit of information about when we really started thinking about transfusion, and the transfusion transmitted issues that we were having was really with the advent of HIV. And so interesting that I talk about this, because in terms of infectious disease, yes, that will always be a concern when we're giving people transfusions of any kind, but that's not the greatest concern, and that's because we have such a limited amount of transmission of infectious disease from transfusions at this point in time. So what we're concerned of are the majority of things that occur because blood is banked, and what happens to blood when it's sitting in a bank. And that's really what I'm going to focus on for you all, but there's always a risk of transfusion-associated sepsis, transfusion-transmitted infections, all kinds of different things. Always keep in mind that healthy patients tolerate mild to moderate degrees of anemia. A lot of studies were done utilizing the Jehovah's Witness population, because as you know, they don't receive transfusions. And being a healthcare provider, I don't know if Josh feels the same way as I do, but if I have a patient having heart surgery who's a Jehovah's Witness, I'll tell you, they make sure that that person doesn't lose a drop of blood. Why can't we do that for everybody? So it gets very frustrating to me. You know, I'm going to tell everybody I'm a Jehovah's Witness when I go to the hospital, so that I'm watched out more carefully, you know, and don't get the blood loss that everybody else does. So the question you have to ask yourself before you give any of your patients a transfusion, and I will say it over and over again, is this transfusion going to benefit your patient or not? Don't ever give a transfusion for any reason other than the fact that the patient clinically requires it because of the improved oxygen delivery, the theoretical improved oxygen delivery, and its clinical presentation. So what I have here on this slide is the fact that there are still a significant amount of practitioners who have a transfusion trigger. They think about a transfusion and they say, oh, if somebody's hemoglobin's less than 10, I'm on the blood transfusion committee at my hospital, and if you give a transfusion to anybody whose hemoglobin's greater than 7, then you're going to go to jail. And they will ask you to write up an entire synopsis of why you thought giving that blood was important when somebody's hemoglobin was over 7. So the 10 and 30 rule has actually been transfusion trigger since 1942. I will always remember that because that's when my parents were born. And it's been a very long time, and it's been since then that we have been trying to create a substitute for blood because of always knowing that blood is bad. There's a lot of bad outcomes from blood. And so again, we need to think about what is the benefit for our patients and always think about that. And of course, as I said before, given the blood donation self-exclusion that patients should be doing and all of our surrogate testing and our nucleic acid testings, we should think that the blood is very safe. But transfusion of the banked blood is really questionable about whether it improves patients' outcome. So these are the troublesome events that I want you guys to think about and have a really good understanding of. The first one is alloimmunization, and alloimmunization can be with anything. It's when your body gains immunity from another individual. So I get a blood transfusion and then I gain immunity from that transfusion, and that immunity is going to be against my own cells. So that's the alloimmunization. When you think of a transfusion, you are transfusing live cells into a person's body. So I think of a transfusion as an organ transplant. So to me, transfusions are equivalent to organ transplants. And some of the studies that I've read, they have shown that the HLA, which is a human leukocyte antigen, is present in people who've received blood transfusions 25 years later. They still have HLA from a foreign source. So the HLA is a pretty big culprit. When y'all, I don't know if anybody here works in transplant medicine, liver transplant units and stuff like that. We do HLA testing before we give somebody an organ of any kind. And generally we like to have at least 3 out of 6 HLA typing to match to make sure that we're not going to have rejection. We don't do HLA for blood transfusions. We do type cross-matching, and we might look at antibodies, but we don't do HLA specific. And these HLA, human leukocyte antigens, are found in the granulocytes, the platelets, RBCs, and they are certainly what is a culprit that's causing different types of alloimmunizations as well as different types of reactions to the patients who are getting the blood transfusion. We have our allergic reactions. We have febrile reactions that are actually not allergic reactions. They are simply secondary, most likely to the cytokines that are found in the supernatant of the blood. So the blood, what blood is stored in is called the supernatant, and I'll talk about that, but there's a lot of junk in that supernatant when the blood is sitting around, and that's most likely the cytokines that are going to cause the febrile reactions. When I talk about the cytokines, think about even in present day today with COVID, patients who are really getting very sick from COVID are having cytokine storms. So the COVID's creating problems with our pulmonary system. It's also creating problems with our cardiovascular system. But one of the greatest issues with COVID is the massive release of cytokine. And cytokine creates this massive systemic inflammatory response, which then has several different mechanisms by which it's going to create problems, including stimulation of our coagulation system, which causes the potential DIC or the blood clots that these patients are getting. So the cytokines are going to cause the febrile reactions. So the ABT stands for allogenic blood transfusion. And I'll talk a little bit about the trolley, which I'd already mentioned. TAS is transfusion-associated sepsis, hemolytic transfusion reactions, and transfusion-transmitted infections, or TTI. And the other thing that we think about is the intravascular hemolysis that can occur with any type of blood reaction, coagulopathies, renal impairment, renal failure, and death. So what are the costs of all of these is what I think about. And what I was reading most recently is that the death rate of transfusion is 1 in 67,000 right now. So that's death occurring within a 24-hour time frame of a transfusion. But we also have studies where we're looking at people 5 years out from transfusions, 15 years out from transfusions, and looking at all of the complications. So I do have a little bit of information from the U.S. Department of Health and Human Services. This is the most recent information I can find. They don't have things that I can find for 17 through 20 right now. But it's just got the fiscal year, and it's got the complication that we're talking about and what the percent of those complications are. So, you know, we can certainly see that trolley was a really big issue in 2014. And I really think right now, I mean, trolley is still up there, but as you can see, then it kind of moved over to transfusion-associated circulatory overload. Keep in mind that when you're looking at research, and I know that you guys are all thinking about that now, that those two differential diagnoses are confused all the time. And there's really a fairly simple mechanism by which you can evaluate if it's transfusion-associated circulatory overload. Do a TEE. I don't think that's being done. I think people are given the diagnosis when they both resemble each other so much. But the differential diagnosis would be to do a TEE. And you could see if there was circulatory overload, because they're both going to have the whiteout chest x-rays, and they're both going to have a lot of problems with oxygenating and ventilating patients. So thinking about differential diagnosis. And this is the reports of trolley cases by implicated blood product. And I wanted to show this because they have always talked about trolley, and they talk about plasma containing products, and people think that the platelets actually create trolley more significantly than the RBCs, but you can certainly see here that the RBCs are definitely implicated, and really at points the highest in terms of problems with blood transfusions. You know, the one thing I wanted to say is I can't see a chat. So Josh, if there are questions, can you see can you follow a chat?
Yeah, I can see the chat, and there are no questions right now, Connie.
Okay, perfect.
Mm-hmm.
Because then I'm going to ask questions of people too. So, so first of all, let's do the trolley. And I feel like most people should have a little bit of a comfortable level with trolley because you all worked in an ICU, and very serious complication of all plasma containing blood products. And it is considered to be a non-cardiogenic pulmonary edema. And a good majority of the studies have implicated those HLA, human leukocyte antigen antibodies. But the other thing too is the biologically active lipids. And I don't know why I don't have that on this slide, but there are lipids inside the supernatant of banked blood. And the lipids actually go to the lung tissue and cause a chemotaxis of fluid movement and neutrophils into the lungs. So the lipids create a chemotaxis of neutrophil movement into the lung tissue, and then fluid follows, and then the patient gets the whiteout chest that resembles the pulmonary edema. Keep in mind that they like to say that it's 1 to 2 hours after transfusion. I have seen it, and it is reported multiple times in the literature to be up to 72 hours post-transfusion. So it can happen far out from transfusion, and it can be certainly misdiagnosed as the transfusion-associated circulatory overload, which is really more of a cardiogenic pulmonary edema because it's volume overload. I think I already mentioned, oh no, I didn't mention this. So one of the biggest culprits, again, being the HLA, and the patients who are going to have a higher level of antibodies in their blood are going to be women who have had multiple pregnancies, because they have an HLA sensitization that occurs within their bodies. So if they have had greater than 2 to 3 pregnancies, then they're going to have a much higher rate of having, if they give their blood, the patients that get their blood have a much higher rate of TRALI. So I just threw this up. I've had it forever, but in 2002, there were 15 cases of TRALI that were linked to one multiparous donor. She was somebody who gave a lot of her blood and created TRALI in 15 people. So keep that in mind, that you become allo-immunized when you are pregnant to the paternal HLA, and that creates this potential problem. Okay, so anybody can have a hemolytic transfusion reaction because the blood banks can make clerical errors before you give your patient your blood. So usually the hemolytic transfusion reaction is because the donor RBCs, so the RBCs that you're going to get as the recipient, are going to be attacked by the recipient's naturally occurring antibodies to the ABO antigens. Okay, so again, that is the transfused donors' RBCs are going to be attacked by the recipient's naturally occurring antibodies to ABO antigens, or any other antibodies as well. I have a listing of the most common RBC antibodies on the bottom. So generally, if it's acute, it will occur within a 24-hour period. You can have a delayed hemolytic transfusion reaction about 24 hours after. And then you have what's called a non-ABO. So your ABO typing and crossing is absolutely fine, but there were antibodies that you have an issue with, and that was what would be listed here. So the patients who are going to have antibodies, and I'm sure you may have heard this before when we do testing, are patients who have had a transfusion in the past. So anytime I have a redo heart, I make sure that they have antibody testing done. Pregnant women can have RBC, or people who have had pregnancies can have RBC antibodies, but they can occur spontaneously. So that's really the latest information that has been brought about, because there are folks that have antibody issues who have never had a pregnancy and who have never had a transfusion. So very interesting that it can happen spontaneously. So something to be aware of with a patient if they're having a transfusion reaction. This is this is information that you just need to know. The recipient type I have off to the left, and then the recipient RBC antigens, so the antigens you would have depending on your blood type, recipient plasma antibodies, and the donor that you would be compatible with. So that's sort of something, you know, print it out, have it. I'm sure you're familiar with this information, but it is important to know this information. Also have an understanding of the testing done. So if you're going to type a patient, a type takes 5 minutes, simple, and it's only going to look for ABO and RH antigens, and the description of it is off to the side. I also wrote that there's a 0.2% chance of incompatibility reaction after this test. If you're doing a type, specific units are not going to be assigned to your patient. So a type is just a type. You're not going to have units sitting there in the lab waiting for your patients. Your patient can be type and screened, and that's screening for the most clinically significant antibodies. And a type and screen takes about 45 minutes. This is showing you what we do to type and screen. And there's a 0.06% chance of incompatibility. But again, a type and screen is just that, a type and screen. It could still take some time to get the blood to the operating room because there's not specific units assigned to the patient. So if you want blood in the room, which sometimes there are procedures where we want to have blood available in the room before the procedure starts, then we're going to type and cross-match. And that's a compatibility between the recipient plasma and the actual blood unit that is going to be transfused. So this is how we can do our antibody screening, etc. Takes the same amount of time that it would take to type and screen. It is more expensive, so you're just not going to haphazardly type and cross-match all of your patients because of the cost. It definitely simulates transfusion within a test tube. So it's a 0.05% chance of incompatibility. But specific units will be assigned to your patient. So you have the availability, they can run to the blood bank and get it if they want it, or you can have it in a cooler in the operating room. Okay, and this here is just a slide talking about the different types of products that we can give our patient, what components are contained in those products, and what would be the indications of receiving those products, and some of the key points. So I don't feel the need to read all of this to you, but I want you to be aware of is the fact that I don't like when they talk about numbers, but we do have standards of numbers in terms of platelets and fibrinogen deficiency. I don't feel so much the same about fibrinogen deficiency. If you have a deficiency, generally that is correct. It can be tested, and then we can give cryoprecipitate, and cryoprecipitate actually works quite well when you have a fibrinogen deficiency. But with platelets, they only talk about numbers. Now, you might have 50,000 platelets, but are they working? That's what I care about. 100,000 platelets, but are they working? So where I work, we wouldn't consider giving platelets or FFP or cryo for that without doing a thromboelastogram. And a thromboelastogram is an in situ test that we do in a tube that is very easy to do. And it will give you, and I'll show you guys later on during the program, I have a presentation on thromboelastogram. And it really tells you the beginning of the clot time is the R time, and that can let you know if the patient's anticoagulated. Perhaps your patient is bleeding because they had heparin and they weren't fully reversed with protamine, but that happens fairly quickly in the test. Should be between 2 and 6 minutes. And then the test shows you the platelet strength. It shows you what percentage of your platelets are working, or perhaps what percentage of your platelets are inhibited if you're on an agent like Plavix. And it tells you how well your fibrinogen is working, your plasma proteins, et cetera. So you can literally look at this and say, yes, my patient should get four bags of FFP, maybe 6 of platelet, 6 units of platelets. So I just think it's super important, and I'm hopeful that many places are looking at thromboelastograms before they just haphazardly give products. Okay, so just moving into transfusion reaction. These are the things that we might observe under anesthesia: hemoglobinuria, hypotension, and bleeding. But there are certain things that are going to be masked by anesthesia. I got this off of documentations, and I'm not so sure I agree with fever or flushing, because we are monitoring a patient's temperature in the operating room, so we should be able to detect if a patient has a fever. So I'm not sure why they're saying that's masked by anesthesia. But things like chills or obviously chest pain, dyspnea, and nausea will be masked. But you certainly could see a patient flushing as well, because we can see that with an allergic reaction. So that's why I put question marks there. But what can happen because of a transfusion reaction? Acute kidney injury, first and foremost. The free hemoglobin really does cause problems within the tubules, which creates a mechanical obstruction. And acidic urine is going to increase precipitation. So you'll see on the slide for treatment that we need to alkalize the patient's urine. And we can do that by sodium bicarbonate, a carbonic anhydrase inhibitor, but those are only PO, so we're gonna have to go with the sodium bicarbonate in the OR. DIC can occur, and that's mostly because the erythrocin is released from that RBC and it activates that clotting cascade. What happens when you activate a clotting cascade, and I know that you all have had patients with DIC, is that you then develop an uncontrolled fibrin formation, which is gonna cause consumption of all of your factors, et cetera, and then you will bleed. So it's generally a consumption type of hemorrhage. And then of course, hemodynamic instability will occur, most likely because the kallikrein system is stimulated and the release of bradykinin causes the vasodilation. So this is what we're gonna do in the operating room or anywhere for that matter, is stop the transfusion. We want to make sure that we're maintaining the environment in the kidney so that the kidney is going to continue to work, particularly within Bowman's capsule. So we give lots of IV fluid. And then the mannitol, there's a lot of controversy about Lasix, to give Lasix or not give Lasix, but the mannitol is very important because it actually changes the environment within Bowman's capsule, and it's osmotically active, so it really will help with the volume going through into the tubules to make sure that the patient maintains urine output. As I mentioned before, alkalization of the urine with sodium bicarbonate. And then there's going to be some responsibilities of sending urine and plasma samples to the blood bank. In our operating room, we have our folder of different situations that might occur. We have one for this, so we know what blood tubes to use, but you certainly can call a blood bank and say, we have a suspected transfusion reaction. What tubes do I need to use to collect my blood samples? But they want the bag of blood back as well. So don't dispose of the bag of blood. It needs to go in a hazard bag and go back to the lab. And our job is to support hemodynamics, which can be a little tricky. Vasopressors are very important, and in association with the volume that we're going to give as well. Okay, I'm going to stop for just a second. Does anybody have any questions? Nope. Okay. Might be. They're all burnt out from your exam, Josh.
Carrie has a question. She wants to know what the kallikrein system is.
Your kallikrein system is, let me go back to that slide too. Okay, so when we're talking about inflammatory responses and what happens with something like a cytokine storm, it is going to affect 3 different systems. And one is the coagulation system. And that's why, so for example, with patients with COVID are having clotting systems. The kallikrein system is within mast, we have release of histamines from mast cells, but also from basophils. So the kallikrein system is going to release bradykinin. I don't know how much more to think about. It's like the coagulation system is the coagulation system, the kallikrein system is the kallikrein system. But what it does is releases bradykinin. So it is activated within the lungs as well, which can cause significant, I didn't write that up here either, it can cause significant bronchospasms. Where else? The kallikrein system is affected with patients who are on ACE inhibitors as well. So there's no breakdown of bradykinin, and that's why patients on ACE inhibitors cough. So I'm going to say probably more active within the vascular system, but also within the pulmonary system as well. Does that help? She's not shaking her head. Yeah. All right. So transfusion-associated sepsis, it's actually waffles back and forth. Usually it's about 3rd, believe it or not, among the causes of a transfusion-associated fatalities. And bacterial contamination is the highest issue that we have. And of course, platelets would be the highest in terms of products because it's stored at room temperature. And other things are stored either frozen or at very low temperatures. In terms of the platelets, the incidence has decreased because now our platelet bags are single donors, whereas you could actually have 6 donors in one bag of platelets before. So now we have single donor platelets. And these are the different bacteria that can cause you to have transfusion-associated sepsis. Some of them very dangerous. So here are the infectious complications. And as you can see, look at the potential for transmitting HIV. 1 in basically 2 million. So these are really things that the patients should not be so concerned about. Hep B is still fairly high, I think. I mean, comparatively speaking to the rest of them. And then we see the emerging infections. These are important to pay attention to, although they're rare. So if I like albumin. I give albumin usually as my volumizer. Albumin The only thing that you have to worry about with albumin is actually Creutzfeldt-Jacobs, which is the mad cows. So because it's a prion, it is not able to be detected and it's not tested within albumin. So keep that in mind. I mean, the incidence is like probably less than 0, but it is something to think about when you're utilizing albumin. All right, so this might help with the other systems that we were just talking about. This is transfusion-related immunomodulation. And this is, again, because we are transfusing patients without doing HLA typing. And so it's an immunization that occurs against the HLA antigens. And what you need to think about is, and this is going to happen to almost every single patient who gets a blood transfusion, just in different degrees, right? And so the one thing that I really like to point out is the non-specific immunosuppression and the antigen-specific immunosuppression. So it has been documented for years that if we give somebody a pack of red blood cells, for sure, that a patient is going to be immunosuppressed. Now, this was, as you see, I wrote there, renal allografts, better outcomes. So this was known way back in the 1960s when they started doing renal transplants, because the kidney transplant recipients who received red blood cells had better outcomes in terms of organ rejection. So great for the kidney transplant patients, but not so great for other patients who we do not want to have immunosuppressed. So know that you're, particularly your surgical patient or your critically ill patient. So keep that in mind with the immunosuppression that can occur. Impaired T-cell mediated immunity, as well as decreased macrophages. And then once again, all of the altered cytokines. When we're talking about cytokines, the ones that I think about mostly with blood are interleukin-1, interleukin-8, and tumor necrosis factor. So you have these altered cytokines, which are going to create bad outcomes for your patients. And the other thing to think about with not just the systemic inflammatory reaction, and you all know what happens with that, patients end up really sick and have a lot of bad outcomes with organ function, all organ functions post. But tumor recurrence, and I find this really interesting. There's a number of studies that show a causal association between transfusion and tumor recurrence. Even in a disease-free patient that has received a transfusion, they have a significant reduction in survival. So what patient population is going to be at high risk for getting transfusion? Cancer patients, because first of all, the treatments that they're receiving for cancer is going to cause them to be anemic, besides everything else with their WBCs and everything else that gets killed because of the bone marrow. Whether they're getting chemotherapy or radiation therapy, that's going to occur. So they're already anemic to begin with, and preoperative anemia is the #1 indication for a perioperative transfusion. So preoperative anemia is the #1 cause of having a perioperative transfusion. And then the tumor fragility. So tumors are very, the reason that they grow so well is because they've got a lot of blood supply that's going to them. So patients are going to be at a much higher risk for bleeding during surgery as well. So these patients tend to be at really high risk of getting blood transfusions. So the other thing that occurs as well is the number of circulating lymphocytes, the white blood cells, as well as human leukocyte antigens. The number of CD4 cells and the T helper cells are significantly declined after having a transfusion. So these are just all things to keep in mind of what can happen if we just say, oh, let's go ahead and give that transfusion. So one of the #1 causes for transfusion-related immunomodulation is the fact that we have leukocytes within the cells. You can't just have red blood cells without thinking that there are going to be some leukocytes in there. So we do leukocyte reduction in the majority of our red blood cells. Probably 80% of your red blood cells in the United States are leukocyte reduced, but there's still about 20% that are not. It is a very expensive process. And what it has shown that, yes, there's a decrease in our non-hemolytic transfusion reactions. Yes, there's a decrease in CMV transmission, and there's a decrease in HLA alloimmunization if we leukocyte reduce our blood. But still, you're not safe. Giving blood will cause an increased infection rate, is associated with a 90-day increased mortality, and it's always been associated with length of ICU stay and increase. So, you know, there are lots of things that we're doing right now that's trying to improve patient outcomes when they get blood transfusions. All right, so adaptation to anemia. In anemia, we do understand that oxygen carrying capacity is decreased. And what we do also know, though, is that our tissue oxygenation is still preserved at hemoglobin levels well below 10. So we're looking at anywhere from 6.5 to 10. Even though your oxygen carrying capacity is decreased, your tissue oxygenation is generally preserved as a mechanism of release of local mediators. And following anemia, we have a lot of adaptive changes, including shift in your oxyhemoglobin dissociation curve, right? So our curve shifts to the right, and that's because we have an increased synthesis in 2,3-diphosphoglycerate. 2,3-DPG is very important because it is what allows our hemoglobin to release oxygen at the tissue level. I emphasize this because a bag of stored blood has a very limited amount of 2,3-DPG. Our red blood cells are quote, alive, but there's no ATP being produced. There's no ATP being produced. There's no synthesis of 2,3-DPG in your banked blood. So we become anemic. We have an increase in our 2,3-DPG, which allows us to release our oxygen to the cells. That's a very important part. We have hemodynamic alterations that are going to occur, such as our heart rate becomes faster. What's our cardiac output? Stroke volume times heart rate. So we're trying to increase our cardiac output to get more flow to the organs and to your tissues. And then the microcirculatory alterations will be your vascular tone, changes that occur, particularly the release of nitric oxide at the tissue level, which is then going to create vascular changes, which will promote your blood to move to your end organs or your tissues. And then, of course, you always have to think about your renin-angiotensin-aldosterone system, which should be activated to help it's more for volume, obviously, because this is for our blood pressure. And so we want to retain both water and sodium in order to maintain our hemodynamic status. So we know how to adapt to anemia. Of course, if you're a healthy person, you're going to adapt a lot easier than our sick patients. Due to time, I just want to show you the different studies that have been done. There's a lot of older studies, and I keep my older studies because they were studies that are so seminal, and the outcomes really haven't changed. So, you know, there's still studies being done, particularly through the Society for Advancement of Blood Management. They've got lots of studies being done, but they really haven't changed in outcomes. So it's been going on for a really long time. And you would imagine the lion's share of studies that are being done are usually on cardiac surgical patients, because those are the patients who are at much higher risk of losing blood or being anemic. They have anemia of disease. They have anemia because anemia of disease can occur because of diabetes, because of kidney disease, because of congestive heart failure. So you'll see a lot of anemic patients in your cardiac patients. So these are just studies talking about what would happen with patients who are anemic, low hemoglobins. And they found out that it really wasn't the low hemoglobin that was adding to any of the poor outcomes as much as it was the patient's comorbidities that were adding to the adverse cardiac events. And low pre-op hemoglobin was associated with those comorbidities, right? But what we definitely know is anemia does create adverse events in terms of postoperative neurologic and renal outcomes. So that's where your anemia is going to really put you at high risk. Preoperative anemia and intraoperative blood transfusions were both independent risk factors for adverse outcomes. So that means that it doesn't matter what the comorbidities are. When it says independent risk factor, it means if you're anemic or if you have a transfusion in your perioperative time frame, they are both independent risk factors for adverse outcomes. And incidence of increased significance as the function of the numbers of the unit. So I say this because I've heard it so many times, we already gave them one transfusion, we may as well give them another. No, you don't give blood transfusions just because you think that, oh, we already gave them one, so what's one more gonna do? The outcome is worse due to the number of units, RBCs, that are transfused to your patient. And this is also something I think is super important because we're talking about maximization of oxygen delivery, but also that's DO2. VO2 is going to stand for utilization of your oxygen at the tissue levels, right? So there's a lot of studies out there that will say, we know that the transfused blood is going to promote oxygen. Stop it, Zeke. 1 second. He always bites her. I don't know what that's all about. Anyway, are you recording this, Josh? Sorry.
Yeah, but we can edit that out.
Edit that right out. Yeah, the Zeke Meister. Okay, so the studies want to say, oh yeah, we know that it improves oxygen delivery because we've got hemoglobin, so the patient's going to have better oxygen delivery. They don't have better oxygen utilization at the tissues level, and that's what's important. And that's because we have a low P50 because we've shifted the blood bank stored RBCs. We're going to be shifting the oxygen dissociation curve to the left. That's not where we want it. We have a depletion of 2,3-DPG, shift to the left. We have depletion of ATP, shift to the left. So we're not going to deliver the oxygen like our native cells will. And so oxygen utilization at organ level is not good, and hemodynamic and oxygen transport parameters are much different and just doesn't work like our normal cells. And I think I might have Suttner's study. That'll be the only study I really want to talk about. So this is just talking about anemia and transfusion. And yeah, anemia predicts adverse outcomes. We know that. But also a lot of studies are going to tell you that the current transfusion practice provides no benefit or is harmful to patients simply because they're anemic. What you need to judge when you're in the operating room, and I'm sure Josh can tell you this as well as I can, that if you have a patient who's losing a lot of blood and they become hemodynamically unstable, there are a number of things that we can do in order to try to become more hemodynamically stable without necessarily giving the blood, but monitoring what your hemoglobin and hematocrit levels are. But then also, when you're thinking about the procedure, the one question that I frequently am going to ask of the surgeon in particular is, are you about done losing blood? So, you know, you can be at a point in a procedure where, yep, we've lost 1,500 doing this hip. We're not going to lose any more blood. So your hemoglobin's, you know, say 8, hematocrit's 24. So, you know, as long as I'm not going to hemodilute my patient by giving them a bunch of volume, that's why I would prefer to give a concentrated volume like albumin, the patient will probably just be fine. Keep them stable hemodynamically. But if you're in a part of a procedure where the patient's going to continue to bleed, most likely that patient's going to require a transfusion. So a lot of thought goes into this though. And what do I have here? Patients who received blood that was stored for more than 2 weeks prior to transfusion had statistically significant increase in everything. So herein lies another problem. We don't get the blood that was donated yesterday because the blood bank wants to get rid of the old blood, right? So all of the blood that you're giving to your patient, I mean, I know I'm always like looking at the blood and I'm so bad. I'm sure the blood bank hates me, but I'm like, oh, this one's fresher. I'm going to give the fresher bag to my patient and I'll put the other bag back. And I suppose that's probably bad resource utilization, but anyway. So I'm going to just quickly tell you what happens to banked blood? This is blood that is stored in a bank. So even if you give your blood thinking, oh, I'm just going to go ahead and give a little bit of blood before my surgery so that they'll give me back my blood. Well, the same thing is going to happen to your blood sitting in a bank as it will from the guy that donated the blood to you. Keep that in mind. First of all, these RBCs are stored up to 42 days. Important to note that. I'm sure that'll be a board question somewhere. It's controlled conditions that we are storing this blood in, so it's not unsafe. But the stored blood undergoes, there's no ATP, remember. So you have a metabolic acidosis that's going to occur. Was that a question that came up? Is that what floated in my screen? No.
Just a comment.
Oh, okay. Uh-oh. Maybe I should look at it.
No, I had when I said I was going to edit that out, and I'm like, I wrote in the chat, I'm like, I'm probably not going to.
Probably not.
Oh, Connie, I was also wondering, do you like approach the grocery store the same way as you're like looking for the freshest blood, like for your produce?
I don't even know, you know, because Chris, he always buys end of life vegetables. Like, this vegetable is end of life. We can't eat this vegetable. You just bought it today. No, you gotta smell it. Anyhow, yes. All right, so your blood is going to be acidotic. It's got lactate. pH is usually 7.2 to 6.6. We already discussed NO2,3-DPG, which we need to release the oxygen to the cells. Decreased ATP, which is our energy. Glutathione, so how important is that? Glutathione is one of our major antioxidants. And so when you're thinking about free radicals, and then the free radicals abstract electrons and create all kinds of problems with the inflammatory system, glutathione being an antioxidant is supposed to be an agent that's going to help prevent or it's going to neutralize free radicals. So we are lacking glutathione. Your potassium can be anything from 3.9 to 80. SNO hemoglobin is S-nitroxyhemoglobin, which is really important in terms of it's a nitric oxide-based vasodilatory response that's going to occur. And so if we, and that's what's really going to drive, the number one thing that's going to drive blood flow to your tissue is the fact that that tissue needs oxygen. And what's going to happen when tissue needs oxygen is you're going to have a release of nitric oxide at the tissue level within the vasculature, which is going to promote dilation at the capillary level to then bring the blood to release the oxygen to the tissue. So we have a lack of S-nitroxyhemoglobin. Your ionized calcium is 0 and your magnesium is 0. And we also know that there's products like citrate that's going to bind the calcium. And so our patients can become very hypocalcemic when they're getting blood transfusion. Even 1 or 2 transfusions can create hypocalcemia. And there's a lot of free hemoglobin. And free hemoglobin is a marker for hemolysis. So we know that these cells have already undergone a certain level of hemolysis before they're transfused. And this is the biochemical. So what did I call the last one? Oh, still biochemical, but these are more changes that occur to the cell. So we know that our erythrocyte, it's biconcave and it's 8 microns diameters, and it possesses deformability. So why do we care about that? So the reason it's biconcave is because it actually increases the surface area of how much oxygen can be held within the hemoglobin on the red blood cell. And the fact that it possesses deformability allows it to stack up in tiny little stacks so that it gets to the capillary level, particularly as it's going through to become oxygenated within our pulmonary vasculature. And then as well, when it goes into the very little capillary vasculature in our periphery. So if it lacks the deformability, it can't stack up, it can't travel appropriately. And so it becomes fragile. It literally within the solution, you know, they just blow up, they pop, whatever, osmotic fragility. And RBC adhesions, they start sticking together. About 30% of your RBCs are going to be dead on arrival. And I already mentioned deformability. So again, they're just not going to work like our native blood cells. And then we now have oxidative issues as well. They're undergoing oxidative damage, and it really does create problems, and it's going to convert your, it's going to cause a conversion of your hemoglobin to methemoglobin, for one thing. Methemoglobin doesn't like to hold on to oxygen at all, if you recall. Methemoglobin's not going to hold on to oxygen, and that's because of the hemoglobin oxidation. It also undergoes denaturation, and basically that leads to our cell membrane becoming destructed. And once your cell membrane becomes damaged, then you have lipid peroxidation, which we know that occurs in any type of injury. Cell injury is lipid peroxidation. And that right there is about the free radicals. And the free radicals do the abstraction of electrons, lipids leak in, and then the cell membrane becomes completely damaged. And then I mentioned before the bioactive substances that are in the supernatant of that blood, the cytokines, which are going to create the inflammatory response. Histamine, we know what that does with, it's going to promote hypotension, first of all, but histamines are also part of the inflammatory and febrile issue. The lipids, I already had mentioned, are what they believe causes the transfusion, the trolley, long word, and then the soluble HLA, which is going to be the immunomodulation factor. So this is all what's going to happen when blood is sitting in the bank. And so I am like really causing issues for blood and to not transfuse blood, but sometimes you have to. And when you think about all of these studies, these are not done on trauma patients who are bleeding to death. These are studies that are done on patients who have lost a certain amount of blood. And the majority of your patients, if you look at the majority of patients who receive blood, the majority of patients who receive blood receive 1 to 2 units. So that's what makes you question, is it really worth it? What is 1 to 2 units going to do for my patient besides all the bad stuff? Is it really going to improve and what do we use for a marker? H&H, right? Oh, look, we gave blood, and the H&H is now 28, and so that's what we use as a marker that we've been successful? No, that's not the marker of success. The marker of success is the increased VO2, utilization of oxygen at the tissue level. So keep that in mind as well. But in hemorrhagic shock, all bets are out. Patient's going to have to get blood transfusions. And we do know critically ill patients do not tolerate anemia as well as our healthier, younger patients. But the goal would be to increase the delivery of oxygen and to increase utilization at the tissue level. I always, in any presentation I give about blood, I always talk about this very seminal study by Dr. Suttner et al. It was in Anesthesia and Analgesia way back in 2004. However, it was one of the studies that really created changes in the anesthesia world, and that's why I want people to know about this study. So again, this was done looking at the patients. Again, the normal, the majority of patients are going to receive 1 to 2 units of blood cells. That's going to, 1 unit should increase your hematocrit by 3%. That's what they say. So you have to wonder, really, is there any scientific expectation that the morbidity or mortality is going to improve with that at all? So he did a study where he just provided the patient with 100% oxygen ventilation, and the other patients received the 1 to 2 units of blood cells. So it was a controlled study, a randomized controlled study. And, when we think about transportation of blood, of oxygen, 2 ways, on the hemoglobin and dissolved or within your PaO2. So your oxygen saturation is going to give you an indication of your hemoglobin saturation with your oxygen. But when you get a PaO2 on your blood gas, that's how much oxygen is dissolved within your blood, all right? And that's very diffusible. because if we know that it's going to go across a gradient of higher concentration to lower concentration. So if we put somebody on 100% oxygen and we look at their PaO2 and it's like 400, and you think about what the partial pressure of oxygen is at the tissue level, which is maybe at 60, you know that that oxygen is going to diffuse across into the tissue level. So what Dr. Suttner did was he did muscle biopsy testing, and he was looking at the utilization, the VO2 of the oxygen. So the persons that were on 100% oxygen had a great utilization of oxygen at the tissue level, not the patients who were getting blood transfusions. So super important study that this was. And this really has led to anesthesia providers being very vigilant about blood transfusions. So these are just a bunch of studies I don't feel the need to talk about. This is all, when they do studies, they look at restrictive strategies versus liberal strategies. Generally, the restrictive strategies are looking at hemoglobins of 7 and 7 to 9. If somebody's a liberal, that's somebody who's 9 or higher who's getting blood transfusions. So they were just looking at mortality rates and a lot of different adverse outcomes because of the blood transfusion. This one here was one of the biggest ones. So when they're looking at outcomes, and I know you guys are all looking at studies and outcomes and variables, the primary outcomes for this multi-centered randomized study with greater than 5,000 patients, which is huge. These were the restrictive transfusions versus the liberal transfusions. And they looked at death from any cause, non-fatal MI, stroke, new onset renal failure with dialysis. And then there were a list here of secondary issues. And this here talked about the fact that the patients that, I love how they do these studies. So this basically was saying that restrictive transfusion strategies is non-inferior to liberal transfusion strategies. So as you can see, when we looked at mortality in the restrictive group versus the mortality in the liberal group, there wasn't a lot of difference, just a little bit higher mortality in the liberal group. So this was a looking at transfusion strategies being non-inferior to the other one. But they're out there, that's a newer one. All right, this I wanted to mention, I don't know if anybody's heard of rejuvenation or Rejuvasol. This was something that came out way back in 2000 and probably 6, I think, when they started doing the studies with Rejuvasol. This was a study that came out in 2011 by Dr. Myers and colleagues. Hasn't gone very far, and it's very interesting. I just haven't had time to really think about researching it more. But this Rejuvasol is something that is added to a mixture that's added to the blood within the stored blood in the bank. It's pyruvate, the IP3, and the phosphate and adenine. These are all things that are going to help restore ATP. And they actually, because of restoring the ATP, created an increase in 2,3-DPG. And they were just looking at outcomes of that bank blood. And so, yes, it actually worked to increase the ATP and 2,3-DPG. But it didn't do anything else. And it's megabucks. So I think it's kind of lost favor. I have not heard a lot about it, but it is a part of the answer. You know, there's new things that are coming out all the time, but this is a part of the answer, Rejuvasol, not being used where I work. So if anybody wants to do any major trials on blood transfusion, these are your goals. We've got to reduce hemolysis. We've got to reduce dead on arrival RBCs, which will cause iron toxicity and vasoconstriction via nitric oxide scavenging. We need to do things to maintain deformability and prevent the aggregation. Maintaining the ATP and 2,3-DPG and S-nitroxyhemoglobin and minimize the oxidative damage. I mean, there's so much that needs to be done. So y'all can see why this is such an issue, that we just don't have the mechanisms to control all of this. We do have some hemoglobin solutions. I think that they're probably used, I don't know if anybody here was in the military, they are probably used more in terms of on the field, because they run at such high colloidal osmotic pressure that you actually can't give more than what would promote something like a 7-gram hemoglobin level, right? And we know that 7 is where we start considering giving transfusions. So this isn't really helpful for us. It also has a half-life of 10 to 30 minutes. That's really short. So limited duration of action, but if you can get somebody to a field hospital or get somebody somewhere, then it is a potential life-saving mechanism. Has a lot of vasoactive properties that create vasoconstriction. And so that's not as promising to get the oxygen to the tissues. It has a really high oxygen affinity, so it doesn't necessarily like to unload the oxygen at the tissue level. And it dissociates into dimers, which we know is going to cause renal tubular damage. So it's going to cause kidney injury. So that's being looked at as well. You know, it's so funny, when I was reviewing this again, I was looking at our volumizers, our hetastarches, and our dextrans, and I don't think I've seen this, I swear, in like 3 years. Josh, have you? Like, crazy.
No, I haven't seen it since CRNA school.
Yeah, so really interesting. I know that there have been a lot of issues with these, but this is the hetastarch, and again, it's volume expanders, but it obviously anything that causes acute normal volemic hemodilution is going to improve blood rheology, but does that really help us with anything else? Definite coagulopathies. So that's why when I first started doing hearts, we were using Hespan, and then we were not allowed to use it anymore because of the coagulopathies that are occurred. This is your dextran. It's got pretty high colloidal osmotic pressure, and patients were having a lot of allergic reactions to this. Again, increased bleeding time, non-cardiogenic pulmonary edema. And then the latest one that came out, I don't know if anybody here got to use Voluven. We actually liked Voluven. We did not use it in the operating room because you cannot give it fast. And if you can't give it fast, you can't give it in the operating room. So this was being utilized in the ICU that I worked in because it was better than all of the other types of volumizers. The one thing that happens with the Hespans and the dextrans is you actually have accumulation of starches in your lung tissue, and also in the kidneys. So it was causing those damages as well. But I can tell you, I never got to use this because it was only in the ICU, and they no longer use it. They've gone to albumin only. So just for an information in case it ever pops up again, this is a list of the contraindications to utilize this Voluven, which seems like there's an awful lot of contraindications. So I don't think you'll probably see that. Let's move to something more important, platelets. So platelets used to be multiple donors, but really starting at about the early 2005, 2004, they started asking for single donor only at this point in time. 1 unit should increase your platelet count 5,000 to 10,000 cells per ml cube. And again, platelet counts of less than 50,000. So I really think that you ought to think about considering the thromboelastogram, the TEG, because that tells you if the platelets are working or not. Platelets do lose the ability to aggregate when refrigerated, so they're stored at room temperature. Hence, they can have a lot of bacterial growth and cause sepsis. So when I talk about platelets, probably not so much FFP, but fibrinogen. The reason I'm more apt to go ahead and feel comfortable with these is because they actually do their job. They work. Platelets work. Fibrinogen works. Not sold on FFP yet, but when I looked at RBCs, you know, are they working is the question. I don't have to ask that when I think about platelets. There's still a lot of downfall of giving a platelet because it's got a lot of plasma. So all of the things for RBCs, the immunomodulation, the trolley, I mean, they can all occur because of platelets as well, but they do their job. And that's the important part of platelets. You cannot give platelets through a warmer, please note. You know, you give your blood products through a warmer. You really should give FFP through a warmer, and we're giving it quicker than what you would give it in your ICUs. You do have to be a little bit careful about how quickly you put FFP in or platelets, because it really does cause significant histamine release, vasodilation, cytokine release with vasodilation, and hypotension. So you do have to be careful about how quickly you give it. But FFP is very cold. So if you've got a patient who's getting a lot of products and a lot of blood, you got to get them warm, or they're just going to end up very, very cold, and we don't want cold patients. So here would be your clinical uses. Again, I've not even looked at a PT or PTT, and I can't even tell you how long. I look at my thromboelastogram and look at my factor assay of activity on my thromboelastogram. So we can use FFP certainly for urgent reversal of warfarin therapy or antithrombin deficiency if your patient's requiring heparin. I don't, did you already talk about that? Heparin, anticoagulations, AT3?
That's next week.
Next week. Okay, so our heparin works because we have something in our blood called AT3. And heparin is going to increase the action of AT3, antithrombin 3, 1,000-fold. But there are patients who actually lack AT3. One of the biggest reasons that you know that is because you give them a big bolus of heparin and you run their ACT, their activated clotting time, and it doesn't change their activated clotting time. So you'll say, oh, was that IV in? 1. 2, gee, maybe they have an AT3 deficiency. So we actually have synthetic AT3. It is expensive, but it comes free of all of the harmful things that can happen if you give somebody FFP. And so we would choose at my facility to use the synthetic expensive AT3 for a patient requiring heparin versus giving them FFP. But FFP contains antithrombin 3 within it, so you can do that. And a patient who's having massive blood transfusions. So there's a lot of stuff out there on massive blood transfusion. There's a lot of stuff on that we're doing the 1-to-1-to-1, which is 1 Paxil to 1 platelet to 1 FFP. And there's a lot of good research that has been showing some success with that. However, there's now better research coming out saying that, and we did that through the military. I don't know if I mentioned that. The military is the one that started the 1-to-1-to-1. So what we're doing though is total looking at thromboelastogram, and we are completely driving our ratios based on our thromboelastogram and whether the patient needs the product or not. So that's that. And then we have our cryoprecipitate, which is antihemophilic factor 8. And it's definitely used for the treatment of hemophilia, von Willebrand's disease, massive transfusion with fibrinogen concentrates, and consumption coagulopathy. I don't give a lot of cryoprecipitate. You know, based off of what we see within our thromboelastograms and knowing when we need to give platelets and FFP, we find that the cryoprecipitate, unless a patient has a total consumption coagulopathy, is not going to be helpful, and it's more harmful than it is helpful. And again, that's dictated by looking at how well is this person's blood clotting? What is this person's blood doing? I love this stuff. PPC, these are purified protein concentrates, super expensive, but they work and they're free of all of the nastiness that we can see in our blood transfusion, product transfusion. So it has fibrinogen concentrates, factor 1. We generally give 70 milligrams per kilogram. These would be the potential adverse reactions. You may have given Kcentra in your ICUs. And I don't know how popular it is in different areas and in different ICUs, but I like the Kcentra. I think it works beautifully. It has an additional factor 9. So the other PPCs frequently only have factor 2, factor 7, factor 10 as well. So now we are doing the one that has factor 9, Kcentra. And this can be used in hemophilia B, and it can also be used for reversal of anticoagulant agent warfarin. So very expensive. Fibrinogen concentrates are equally as expensive, but the prothrombin complex concentrate itself, Kcentra, is very expensive. So there's lots of other things that we can do then. Let's just make sure the patient doesn't bleed. That's really the number one thing. And one thing that we like to utilize is DDAVP, which is desmopressin acetate. DDAVP is the glue to the von Willebrand factor. It stimulates the release of the von Willebrand factor. So people who have von Willebrand's disease are frequently on DDAVP unless they have a very severe form of von Willebrand's disease where they have no factor, then they just simply have to get the von Willebrand factor, because DDAVP will not work for them because they won't have a release of their von Willebrand factor. So if I have a patient who's going on bypass to have valve surgery, or if they're going to be on bypass for a certain amount of time, I'm always going to order DDAVP to give to them when they come off pump, and it helps significantly to decrease their bleeding. It releases TPA, tissue plasminogen activator. It releases prostacyclin. It's given for hemophilia A and von Willebrand factor, and it also can be given for aspirin-induced platelet dysfunction. The next thing we have is recombinant factor 7. Look at the price of that, $15,000. I'm not making that up. So isn't that ridiculous? Big pharma should just be ashamed of themselves. Now, this has been, it's kind of funny because in a lot of studies that I read about factor 7, they call it like the miracle drug that, that the person would have died without it for sure, blah, 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 blah. I've used it a handful of times, perhaps because of the exorbitant cost. We don't use it until it's a last ditch effort, and that last ditch is too late. That's kind of my assumption, because it's never worked on any of my patients that I've used it on. But it is approved for hemophilia patients. It enhances thrombin generation on the activated platelets. But again, it's very expensive. And I think also within the cardiac population, when they started using it, because of the thrombotic complications, it was causing the anastomosis of the graft to become occluded. So the cardiac surgeon said, no, we're not using this unless, it's last ditch, and we use it last ditch and the patient dies anyway. Amicar, you will use this in your, some places might use it in orthopedic, but usually they use TXA, tranexamic acid. We use Amicar in, again, the cardiac operating room. It is a synthetic lysine inhibitor of plasminogen. So this is what it does. Significant reduction in blood loss and transfusion requirements. This is your dosing. It reduces perioperative blood loss. It decreases autologous blood donation, transfusion of blood products, and overall cost and complications. So the one thing to keep in mind about Amicar, which I don't have on this slide, which you will probably hear about later, is that you have to be careful for patients who have any type of renal dysfunction, chronic kidney issues, and you really do have to be careful in your population of patients who are, for example, if they're going to go on bypass and they're going to be chilled, if we put them on ice, it really does cause destruction to the kidneys. So, and none of these things come without their issues. So that's your Amicar. And the next one that you guys will definitely be using, my assumption is, because all of my colleagues use it, is the tranexamic acid. This is used in 2 arenas in particular, orthopedic surgery and obstetrics. And so it is a competitive inhibitor of plasminogen activator, significantly reduces intraoperative bleeding. This was a study, obviously, Dr. Fay, by a mean of 408 mLs. I don't know who measured that one, but decreased the probability of receiving blood transfusions by 49%. But the best news of it was all of the studies they looked at, one of the biggest things we were concerned, because many of these items could potentially cause hypercoagulability. When you have surgery, you are going to be hypercoagulable, because when your body sees an incision and your body starts to lose blood, your body is going to incite the coagulation system. So within 24 hours, you are going to be hypercoagulable. And they were concerned that if we did something that actually reduced bleeding by being an inhibitor of plasminogen activator, will it cause clotting? There were so many studies that were done, and the rate of DVT in our orthopedic population was not affected by the use of TXA when compared to controls. So it is a very safe agent to give for that population. How much longer do I have? 10 minutes? Or minus 6?
No. So class finishes up around 2.
Okay, so let me just flip through real close because I've only got like I've got like 10 slides or less than. This is just dosing that you will have on the slides that I gave you. This is something that I'll talk to you all about later because this here is our answer of how we're not going to be able to not have to give patients blood in the future, patient blood management. And I'm a very strong advocate. It's a multidisciplinary therapeutic approach to patients who are anemic because there is no reason why a patient should show up in your operating room anemic. There are many things that we can do. If it's emergency, if the patient's bleeding already, if it's a ruptured thoracic aneurysm or whatever, clearly this is not going to be indicated. But I cannot tell you how many of my patients come into the operating room to have, their valve taken care of, their mitral valve, whatever, tricuspid valve, whatever valve, aortic valve surgery, or even a CABG patient who comes in, 2 weeks after, and they've got a hematocrit of 28. Yeah, I can't start a case with a hematocrit of 28. That patient is going to end up with blood. Number one indicator of blood transfusion is low H&H. So anyway, this is just stuff I have on patient blood management, talking about erythropoietin and iron. There's a lot of fights with insurance companies to be able to do this, talking about bloodless surgery on this slide. These are more about antifibrinolytics and the TXA and the Amicar. I talked about other autologous transfusion. Cell Saver, it is equally as bad because when you're sucking stuff into the Cell Saver, you're sucking in everything that's in the field: bone marrow, bone fragments, tissue, fat, all kinds of things get sucked in. Yeah, we spin it down, try to clean it up as best we can, but then we're giving back significant amount of blood that has great hemoglobin and hematocrit, but it lacks all your coagulation properties. So after you give about 1 liter of Cell Saver back to a patient, you're going to have to consider a thromboelastogram to see if they're going to need platelets and FFP. We can do that post-operative for blood collection as well for our orthopedic and our cardiac patients. I don't need to talk about that. I can talk about that later when you're in the operating room. And this is just talking about patient blood management programs and what we do. We have a very active patient blood management program at my hospital. So I will leave you with this. The benefits of transfusions are theoretical and the risks are fact. Transfusion of allogenic blood is going to represent a major risk for immunosuppression, adverse outcomes in the perioperative period, and it indeed stands out as an independent risk factor of adverse outcomes. So transfusion has to be considered carefully, very carefully, after thorough evaluation and of the risks and benefits. Accepting a lower threshold in terms of your transfusion is not only safe, but it can decrease overall patient exposure to all the potential harmful effects that we talked about of stored blood. Alternatives to RBC transfusions certainly warrant further studies. And until the benefits of allogenic transfusion are well defined and the risks of this therapy are reduced, we really have to err on the side of safety and try to avoid the use of allogenic blood whenever possible. Okay, these are the references. All right.
Well, Connie, that timing was expertise. And thank you for sharing all your knowledge with us.
I don't know how to stop sharing my screen. Oh, right there.
You can go to stop share. Yeah. There were 2 questions that were in the chat that I didn't get to. One was John was wondering what nitric oxide scavenging is.
It destroys the nitric oxide so that it no longer is going to be effective at promoting the vasodilation at the capillary level.
Mm. Great. John, does that cover it for you?
Where is John?
Yeah, I was just trying to figure out how it could be a vasoconstrictor, I think is what the slide said. So but that makes sense.
Yes.
And then Jessica is wondering if purified protein concentrates are synthetic.
Yes. For
Okay.
our Jessica. Yes.
Excellent. All right, well, those were the hanging questions that were in the chat. Does anyone else have any questions for Dr. Lorette?
You're welcome, Kara.
Mhm.
All right.
And then remind me, do the students have a meeting with all the faculty today? Or I get confused. I know it's alternating weeks. I just can't remember which week we're on.
I think it's next week.
Next week. Okay.
Or it's next week, yes. Well, I'm positive it's next week because I have a meeting with Danielle at 3. Yeah. Yeah. All right, everybody. I hope your test went wonderful. I'm sure this was so much information to hear after you take a test too. And don't fear to give blood. One of my students told me once they felt like when they came to tell me they had given blood, they felt like they were going to the priest to confess some major sins. But that's not what this is about. This is just about an awareness of what it's about, and the risks and benefits. But everything we do, we have to look at risks and benefits of every single thing that we do. So thank you, everybody.
Great. Thank you all. Thank you, Connie. And I will see you next week.
Will you see me next week too?